The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hello, welcome to Knowledgeable Provider. I'm your host, Jody Marks, talking about a very interesting clinical topic today, Myasthenia Gravis. I've always been interested in this for whatever reason. I think the mechanism behind it is really cool. I guess it's not cool if you have it, but just a very interesting disease process. We've made it to M in our Alphabet Soup series. Again, we're skipping L. Hopefully we have a special guest coming on at some point to cover an L topic, so we're putting that one on hold. We're tabling L and moving on to M. First, in medical news, a lot's happened in the past couple of weeks. I'm not going to really dwell on any of this today, but there are some big things to talk about. The federal vaccine schedule has changed dramatically. On January 5th, Health and Human Services issued a memo implementing major changes to the federal vaccine schedule for children. This will reduce the number of routine vaccines recommended for all children from 13 down to 7. The ones that are no longer recommended for routine use by all children are rotavirus, COVID-19, influenza, hepatitis A, hepatitis B, and meningococcal vaccines. They have narrowed those down to being recommended for more specific groups based on supposed risk criteria. There is still language that there should be informed decision-making between healthcare providers and patients or parents. They are also reducing the number of recommended HPV vaccines. Until now, it's been if you started the HPV vaccine before age 15, you get 2 doses, and if you do it after age 15, you get 3 doses. Now it's just 1 dose is recommended. Supposedly, this is not going to change insurance coverage of vaccines, so if parents choose to get these vaccines, supposedly they're still going to be covered by insurance. I'll believe that one when I see it. The exception to that would be that HPV vaccine. So if you want your kid to have more than 1 dose of that, you may have to pay cash for the additional dose or doses. I'm looking at a Kaiser Family Foundation article about this, and compared to other civilized countries in the world, this brings us closely in line with what Denmark does, but us and Denmark are now an outlier compared to Australia, Austria, Germany, Greece, Ireland, Italy, Japan, New Zealand, Spain, and the United Kingdom, whose recommendations are all more in line with what we have been doing previously. I hope you all know where I stand on this by now. I am certainly not in favor of fewer vaccinations. I will continue recommending all of these vaccines if anybody asks me. We don't take care of newborns or young children in my practice, so I'm not going to be involved in these discussions with my patients generally. But if anybody asks, I will certainly recommend the full number of vaccines before this change happened. It's just hard for me to believe this is not going to bite us in the ass. You know, it seems like a no-brainer to me. If you can get a shot and avoid getting some horrible disease, that seems like a pretty easy decision. Or if you can get your kid a shot to prevent them from getting and dying from some crazy disease, why would you not do that? I don't like the direction this is going. I don't like the distrust that has creeped in about vaccines. I don't understand it. I think it's insane, but that's where we are right now. It'll be interesting to see what happens if and when this administration ever goes away, see if all this reverses or what's going to happen. I don't know. Who knows? For right now, I think we all better brush up on our knowledge of these diseases that none of us have ever seen before because these vaccines exist. The other big story affecting clinical medicine that happened recently, and I very much agree with this, is the removal of a lot of the black box warnings from hormone replacement products. You know, famously, there was that women's health study back in the 90s that was sort of misinterpreted, and everybody decided that hormones were very dangerous, and now we got to get everybody off of hormones, and they're looking at that differently now, and the pendulum is swinging back the other way. And it's looking like probably it's a good idea to do hormone replacement for a lot of people. There are still risks, of course. The main ones you think about being blood clots and certain types of cancer. I think they are still leaving in place the warnings about uterine cancer with estrogen-only products. But outside of those specific situations where there really is high risk, it sounds like we should be a lot more liberal in offering hormone treatments to our patients dealing with menopausal symptoms. The Curbsiders did an episode about this recently that was excellent. It's episode 507 that came out on December 8th, 2025. It's called Swinging the Pendulum on Menopause Care with Dr. Rachel Rubin. Fantastic overview of different hormone products and strategies and who can have this and who can't. That's a really good episode if you want to learn more about that. So there's something I agree with this administration on. This is a Health and Human Services Robert F. Kennedy-esque program. So there's something I can agree with. There's something I can get behind. The other big story is that the House of Representatives passed a bill to extend the ACA subsidies that I talked about in the last episode. They must have heard what I said. Obviously, my episode prompted Congress to get in gear and do that. So yeah, Congress, it's about time you start listening to me. You're welcome, everybody. You're welcome. No need to thank me. So that has to go to the Senate now, of course, but it looks like maybe those subsidies will end up getting extended. So yeah, good news on that. Links to information about all these stories can be found in the show notes. Now on to our clinical topic, myasthenia gravis. This is an autoimmune disorder where you have antibodies to acetylcholine receptors in the postsynaptic membrane of the neuromuscular junction. So it's the muscle side of where the nerve joins with the muscle. Those antibodies bind to the receptor and they prevent acetylcholine from binding to the receptor, which prevents the muscle from doing what it's supposed to do. This is actually the most common disorder of neuromuscular transmission. I've met a handful of patients who have it. I don't think I've ever diagnosed it, but it is something that you will see. You'll meet people that have this. There are other subtypes of MG that involve different antibodies. About 90% are going to have the antibodies against the acetylcholine receptor. Some people with myasthenia gravis don't have those antibodies, but they instead have MuSK autoantibodies. This is an antibody against the muscle-specific receptor tyrosine kinase. It's pretty uncommon to have both MuSK and acetylcholine receptor antibodies, but it is possible. So a little bit different mechanism there, but the result is the same. Another form of myasthenia gravis is when you have antibodies to LRP4, which is lipoprotein-related protein 4. That's a subunit of the MuSK complex. So again, different mechanism, but still kind of the same result. It all falls under the same umbrella as far as clinical manifestations. You can also have myasthenia gravis where you do not have any of these three antibodies. This is called seronegative myasthenia gravis. Same clinical manifestations, same electrophysiologic findings. And I don't know if we know much more about seronegative myasthenia gravis than that. Apparently, there are some little types of acetylcholine receptor antibodies that are not detected by common assays. So maybe it's just that these antibodies are not being detected in some people. I don't know. I don't know if we know much more about it than that. T cells can play a role in myasthenia gravis. They are capable of binding to that acetylcholine receptor and cause B cells to produce antibodies. In most patients that have the acetylcholine receptor antibodies, so the most common form of myasthenia gravis, there is going to be some abnormality with the thymus, hyperplasia of the thymus in 60 to 70%, and thymoma in 10 to 12%. So a lot of times if they take the thymus out, the disease often improves or goes away. Clinical manifestations of myasthenia, because the acetylcholine can't get from the nerve to the muscle, it makes the muscle not be able to contract as much, so it makes the muscle weak. So the primary clinical feature of myasthenia gravis is fluctuating muscle weakness, mostly involving ocular, bulbar, limb, and respiratory muscles. They separate the clinical forms into ocular and generalized. So with the ocular form, the weakness is limited to the eyelids and the extraocular muscles. So this can give you ptosis, double vision, not being able to close your eye closure weakness. Generalized myasthenia involves a combination of all the other affected muscles. It can be separated into classes based on severity. So the spectrum there goes from class 1, which is isolated ocular muscle weakness, up to class 5, which is intubation due to respiratory muscle weakness. I don't think that classification would really be important for my role. I think that would be more of a neurology classification. But if you see that in somebody's diagnosis, that's what the different classes mean, just how severe it is and how much it affects, essentially. This can present at any age, but it tends to be most common in females during the 20s and 30s, and in males in the 60s, 70s, and 80s. So younger females, older males, most commonly is when it shows up, but it can show up anytime. So when you see this muscle weakness, it's true muscle fatigue, not like feeling tired, but the muscle itself cannot work anymore, becomes weak. In fact, just feeling tired but not being weak is not consistent with myasthenia gravis. You know, everybody comes in and says they're tired, but that's a lot different thing than muscles are actually clinically weak. So these people complain of specific muscle weakness, not generalized muscle fatigue. Kind of the classic symptoms, the initial symptoms in up to 2/3 of patients are going to be the ocular symptoms. Really kind of the classic thing I think of is the eyelids drooping after a while, the muscles of the eyelids becoming weak over time. Again, the eyelid muscles and the extraocular muscles can be affected, so it's not just the eyelids, but it's the movement of the eyeball itself. Important to remember that pupillary function is not affected by myasthenia gravis, so if something's going on with the pupil, it's not from myasthenia. For generalized myasthenia, very common presentation is weakness of the facial expression muscles or the muscles affecting the mouth, also known as bulbar weakness. This can be an important factor in respiratory compromise because there's a risk of aspiration, obviously, if your muscles in your mouth are not working as well. Of course, this can affect speech, can affect your jaw with prolonged chewing, can affect your swallowing mechanism. And then with facial expression, when those muscles fatigue, of course, the facial expression is just going to become flatter. There's a characteristic myasthenic sneer when the people attempt to smile. So the middle of the lip raises up, but the corners of the mouth don't do anything. Myasthenic sneer. I've never heard that before. With generalized myasthenia, you can also see weakness in the neck muscles and the muscles of the extremities, but those are pretty uncommon presenting symptoms. Fewer than 5% of patients are going to have those as presenting symptoms. And respiratory function, even though those muscles are commonly affected in generalized myasthenia gravis, which leads to trouble breathing with exertion, but that's pretty much never going to be the initial symptom. On the flip side, of course, the respiratory muscles not working can produce the most serious symptoms or the most serious complications. So a lot of times early in the disease, you see these kind of episodic symptoms. You'll have normal periods with no symptoms that can last hours, days, weeks. But over time, typically the weakness becomes more severe and more persistent or more frequent. It takes a couple of years usually to reach its peak severity. And a lot of times you'll see new symptoms start to develop within weeks or months of the initial presentation. There's always a question of whether somebody with ocular manifestations is going to progress to generalized myasthenia. Of patients who do present with ocular myasthenia, about 2/3 of those will go on to develop some degree of extremity or bulbar muscle weakness. If that's going to happen, it's generally going to happen within the first year after those ocular symptoms develop. And it's definitely going to develop within 3 years. So if you have ocular myasthenia and you make it 3 years without developing any other muscle weakness, that means you just have ocular myasthenia, most likely. And apparently there's really no way to reliably predict who's going to progress and who's not. Diagnosis: we should suspect this anytime we have a patient with true fatigable muscle weakness, especially if that involves the eyelids or the eyes. But obviously there are a lot of other things that can cause weirdness with the facial muscles, eye muscles, skeletal muscles, so a big part of diagnosing it is ruling out other things. There are several little bedside maneuvers that you can do to look for this, but they're not very specific for myasthenia, so these are not considered confirmatory tests. There is one helpful test called the ice pack test. It turns out neuromuscular transmission actually improves when the muscle is at lower temperature. So in someone with myasthenia, if they have the ptosis, the eyelid drooping, you can directly cool the eyelid muscles and the symptoms will improve. So you assess somebody's baseline, they have this ptosis, this droopy eyelid. So you put an ice pack over the closed eyelid for 2 minutes, and then you see what happens with the ptosis if it gets better. So if it does get better, that's considered a positive result, and that is about 80% sensitive for ptosis related to myasthenia gravis. That's only helpful when the symptoms affect the eyelid. It doesn't work for the extraocular muscles. Obviously, you can't get the ice pack back to where those extraocular muscles are. Please don't try. The test that we all learned about when we read about this in school is called the tensilon test or edrophonium test. Apparently, that's not really a thing anymore. You can't even get that drug anymore in the United States as of 2018. So this is a thing that has certainly fallen out of use, fallen out of favor. The way it works, or worked, I guess, is you give somebody this edrophonium, which is an acetylcholinesterase inhibitor. It has a very rapid onset and it goes away pretty quickly. So, of course, being an acetylcholinesterase inhibitor, it increases how much acetylcholine is available in the neuromuscular junction. So you give it and you get this essentially an immediate increase in muscle strength. Apparently has an 80 to 90% sensitivity, but it is prone to having false positive and false negative results. And there's some other problems with it. So interesting, but not clinically relevant anymore. Another way of testing for this sort of accidentally is if you're trying to reverse neuromuscular blockade and it doesn't work. So someone has a paralytic for general anesthesia, say, and then they go to reverse that after the surgery and the reversal agent does not work. I saw this happen once when I worked in PACU. I don't know if it was because of myasthenia gravis or if they had something else, but that's exactly what happened. The reversal agents just did not work, and we just had to sit there with them for hours until it all wore off and they were able to wake up. I say wake up. Of course, if you're paralyzed but not sedated, you are aware. So we had to be very mindful that even though the patient appeared to be asleep, they were not. They were just paralyzed. And what a horrible thing to have to go through. It seems like the anesthesiologist gave it a name or actually gave it a diagnosis of what the patient had, but I cannot remember. I don't think it was myasthenia gravis. I think it was something else. I'm trying to Google search it, but I can't come up with what I'm thinking about. But anyway, if this happens, it's possible the patient has myasthenia. So nowadays, typically the way this is diagnosed is by testing for antibodies. Again, the most common ones are going to be the acetylcholine receptor or AChR antibodies. So that's what you're going to test for initially if you suspect myasthenia. If you don't find those antibodies, then you can move on and test for the MuSK antibodies. Those two are going to cover most patients with myasthenia. Typically, they do not test for the LRP4 antibody unless the diagnosis is still uncertain after the patient has had electrodiagnostic testing. So really, acetylcholine receptor antibodies and MuSK antibodies are the two that we're going to be testing for. The electrodiagnostic testing is used to confirm the diagnosis when the situation's still uncertain, so maybe the clinical features are not typical and the initial antibody testing is either negative or you have very low titers of those antibodies. You can do nerve conduction testing with repetitive nerve stimulation. You can do EMG, electromyography, or you can do single fiber electromyography, SFEMG, which is the most sensitive diagnostic test. If there's still a question of the diagnosis after serologic and electrodiagnostic testing, you can move on and do brain MRI, CT or ultrasound of the orbits, or lumbar puncture. Because the thymus is also involved, anybody diagnosed with myasthenia should also be checked for thymomas or other autoimmune conditions. So whenever somebody's diagnosed with myasthenia, they should get a chest CT or MRI to look for a thymoma. If they find a thymoma, or even in some patients who do not have a thymoma, they will consider taking out the thymus. Good idea to check thyroid function in everybody who has myasthenia to look for autoimmune disease affecting the thyroid. As far as any other specific testing for autoimmune disease, that would be based on the patient's other symptoms or the patient's other clinical features that would suggest a different autoimmune disease. Treatment, there are pretty much 4 things you can do. You can give acetylcholinesterase inhibitors to help treat the symptoms. You can give chronic immunotherapies to treat the underlying immune problem. You can give short-acting immunomodulating treatments, so like therapeutic plasma exchange or IVIG, and or you can take out the thymus. Those are your 4 options for treatment. So for most patients initially, they're going to be treated with pyridostigmine. That's an oral acetylcholinesterase inhibitor. Neostigmine is also available. Typically, that neostigmine is what they're going to give IV after surgery or after anesthesia to reverse a paralytic. It is available in oral form, but that's not commonly used. Commonly, it's going to be the pyridostigmine. It is a little bit hit or miss whether that pyridostigmine is going to work. It's either going to work really well or it's not going to work at all. Especially in patients that have the MuSK antibodies, it's probably not going to work. Sometimes you can see sort of a mixed bag where you give the pyridostigmine and some of the muscle weakness improves, but not all. So maybe the ptosis gets better, but they still have double vision. Usually the limb and bulbar muscles are going to respond better to the pyridostigmine than the ocular muscles. Sometimes you can just treat the symptoms with the pyridostigmine and that's all you need. For adults and older kids, generally you're going to start the pyridostigmine at 30 milligrams 3 times a day, given with meals, and give it a few days to see how they're going to tolerate it. Obviously, because of the mechanism, you're looking for your cholinergic side effects, which you can treat with something like glycopyrrolate. After that initial trial of pyridostigmine, you can go up on the dose by 30 milligrams every few days until you get to where it's working well or they can't tolerate it anymore. Usually the maximum dose is 120 milligrams every 4 hours. And almost all adult patients are going to require a total daily dose of less than or equal to 960 milligrams. So that's the total daily dose divided between 4 and 8 doses. Dosing's different for kids. It's 0.5 to 1 milligram per kilogram every 4 to 6 hours with meals, titrated up slowly in the same manner to a maximum dose of 7 milligrams per kilogram in a 24-hour period. This has to be individualized. There's not really a single schedule that fits everybody, so you just sort of have to start it and titrate it and toy with it until you get to the right place for an individual patient. If you have a patient who remains symptomatic despite being on a therapeutic dose of the pyridostigmine, then you move on to immunotherapy. Usually that is a steroid initially, and then ideally they can move on to an immunosuppressant agent like azathioprine or mycophenolate. If they have a thymoma, they definitely need to go get their thymus taken out. If they do not have a thymoma, but they have generalized myasthenia with acetylcholine receptor antibodies and they're younger than 50 years old, the thymectomy is probably going to be beneficial. In other patient groups, it's not as clear that it's a good thing to do, so more individualized decision making there. You can have a severe form of myasthenia called a myasthenic crisis, which can cause life-threatening respiratory failure. Usually those patients are going to get IVIG because it is rapid acting. You can also do plasma exchange or some different antibody-based biologic therapies. A lot of myasthenia patients are going to have periods of exacerbation that are not severe enough to be considered a crisis, but still a worsening of symptoms. And the treatment of those just sort of depends on the situation. It's still the same options for treatment, just depends on what the symptoms are and how quickly you need the treatment to work. With mild flares, usually the first choice is just going to be to increase the dose of the pyridostigmine or start steroids. I guess that's what I have some experience with. We had a patient, unfortunately, pass away from COVID during the height of the pandemic, but this person had myasthenia and would fairly frequently come in with not crises, but flares, and steroids were always very helpful for that patient. It got kind of sad toward the end of their life. Again, they didn't die from myasthenia. They ended up dying from COVID, but their neurologist was very dead set against them taking any more steroids because they had taken a lot of steroids. And they would come in and just beg, literally beg for steroids because it made them feel so much better. And that always just broke my heart. That was a hard situation to deal with. I remember that. There are a bunch of different biologic therapies available these days. This would not be something that we would initiate in primary care. And also, I can't pronounce the names of any of them, so I'm not going to go over those. But there are definitely a bunch of monoclonal antibody medications that are available for this. So there are other things out there that neurology would have access to as far as long-term treatment for myasthenia. Another important consideration when you're taking care of these patients is to avoid medications that may exacerbate the myasthenia. Anything that directly affects neuromuscular transmission, obviously, so aminoglycosides and any kind of neuromuscular blocking agents can be problematic. There are a lot of medications that can be problematic. Really, a good rule of thumb is just to assume that any medication may cause a problem and just watch it if you're giving these people a new medication. Some of the more common things are fluoroquinolones, macrolides. There was a macrolide called telithromycin, apparently that was associated with really severe exacerbations of myasthenia gravis. It was taken off the market in the United States in 2016 and at some point was discontinued worldwide, so that's not a thing anymore. Magnesium sulfate has a significant inhibitory effect on acetylcholine release, so it is relatively contraindicated with myasthenia. Penicillamine can induce myasthenia, so it should be avoided. There are some of the checkpoint inhibitor medications that can trigger autoimmune myasthenia gravis. These are ones that are used in cancer treatment. I'm going to try these two. Nivolumab and pembrolizumab are two specific examples. Cardiac drugs, all beta blockers, procainamide and quinidine, all those should be used with caution. Statins have been reported to unmask or exacerbate myasthenia. They're not contraindicated. You just have to use them with caution and watch these people more carefully. A few other potential problematic drugs are lithium, phenothiazines, which would include chlorpromazine and prochlorperazine, some of the anti-seizure medicines, including gabapentin and phenytoin, and calcium channel blockers. So there you go. Progressive muscle weakness, suspect myasthenia gravis, particularly if it involves the eyelids or the extraocular muscles. If it's an eyelid thing, you can do a bedside test with an ice pack. Next step would be to check for acetylcholine receptor antibodies. If those are negative, go on and check for MuSK antibodies. If there's still a question, move on to electrodiagnostic testing. Once you've confirmed the diagnosis, think about the thymus, and then pull out your pyridostigmine and hopefully make the patient better. I think I would be comfortable doing all of those things. I would probably go on and refer the patient to a neurologist just because there are so many different options for long-term treatment. But I feel like I would be comfortable getting a patient to that point where we've established the diagnosis and we've at least tried the pyridostigmine to see if it helps them get better. That would be my thought from a primary care standpoint. If you know anything about myasthenia gravis that I forgot to say, or if I said anything wrong, please reach out and let me know. Thank you so much for listening. Special thanks to our Patreon supporters. I hope that everyone has a great week, and I will talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.